The first thing I want to stress before I even start is the important role of a sonographer. We're really critical in diastology evaluation, getting accurate information, accurate technical, good data, reliable data. At the end, diastology is data. So we're applying those either to their current guidelines, our future guidelines, our special population guidelines. So it's really important to make sure we're really following what we're supposed to do as sonographers to make sure we're providing really reliable data for the staff. My objectives are a brief overview of the current parameters that we use for special populations for diastology, to discuss the challenges in special populations, how we adapt our diastology evaluation for complex cases, and then we'll look at a case of AFib. So as Dr. Klein showed earlier, this is our current algorithm that we use. As sonographers, we typically focus on this group here of the E to E prime. We look at our E lateral and septal E prime velocities, TR velocity, and also our LAVI. Who uses algorithm 1, or how do we use algorithm 1 for our patients? Is typically going to be those with normal LV ejection fractions and no myocardial pathology. So in our case at the Cleveland Clinic, not many patients actually fall into this algorithm 1 category. As we move on to algorithm 2, we now are going to add our E to A ratio and also an E velocity in some cases, and then again looking at our E to E prime ratio, our TR velocity, and also our LA index volume, or our LAVI. The folks that fall into this algorithm 2, as Dr. Klein alluded to earlier, are those with extensive cardiac history, known CAD, pathological LVH, hypertensive cardiovascular disease, cardiomyopathies. If you have established HFpEF, if you have some positive parameters from that first algorithm, then also a reduced EF. We do have exclusion criteria, which some of these special population folks fall into this exclusion criteria. Those with a pacemaker with ventricular paced rhythm. If you have mitral valve disease, that's going to be greater than 2+ or moderate MR, severe MAC, stenosis, or some sort of repair or replacement. We're not going to call diastology on these patients. Plus 2+, greater than 2+ AI, LVADs or heart transplants, and then again AFib flutter. As sonographers, we typically are looking at these four parameters when we're doing our diastolic assessment. We're looking again at that TR velocity, our E prime, our mitral valve flows, our E and A ratios, and E velocities, and also our LAVI. So this doesn't work all the time when we're looking at special populations. These aren't able to be applied to those often. Sometimes they can, sometimes they can't, depending on what pathology we're looking at. So we need to really think about, as sonographers, how we can expand our alternate parameters. So we need to look at other things which we'll go through, depending on which pathology we're looking at. So it's something to just be aware of and be cognizant of, that these are not always going to apply to every single patient that we're doing. So why don't these apply to our special populations? Because our current standard guidelines are based on studies from a general population. They sometimes don't account for unique physiological or pathological variations in certain subgroups. Special populations that the guidelines currently label as special populations include valve or some sort of valve disease like moderate MR, mitral stenosis. We have severe AI. Also, when you have cardiomyopathies like restrictive or hypertrophic, we also have heart transplant and LVADs, and then also we have some arrhythmias such as AFib, aflutter, bundle branch block, or sinus tachycardia. There are a couple general rules you can use to look for LV filling pressures when you're looking at special populations. One of them is using your PASP, or your pulmonary artery systolic pressure, from your TR jet. That typically is reliable to indicate increased LA pressures, unless you have a couple issues here with diseases or pulmonary vascular diseases. Also, if you don't have aflutter, you don't have AFib, you don't have mitral valve disease or transplant, you can look at LA volume as well. If you have an increased LAVI, when your RA size is normal, that can help suggest that there is elevated LA pressures as well. So same as we do for special populations, as we do for our standard populations, this requires a comprehensive approach. That is no different than when we're looking at our typical patients. And also our conclusions should not be based on single parameters. This is a nice visual just to kind of summarize what we'll be talking about. So this is a list of our special populations up top here that I just mentioned earlier. And in this bottom left-hand corner is sort of what we typically think of as standard indices for our patients, the E to E prime, the E prime velocity, our TR velocities, our LAVI. As we explore more supplemental parameters, on the right-hand side, we can look at our pulmonary veins, as we talked a little bit about earlier, our A velocities, our A reversal velocities, our systolic filling fractions, our decel time of our diastolic filling, our diastolic velocity. Again, making sure as sonographers we're getting really good pulmonary veins. A lot of times that's overlooked, and it sounds like the new guidelines, we might go back to some of that. Our mitral valve inflow, looking at our variation of beat-to-beat variation in our E velocities, and then looking at our decel time and peak acceleration rate with our E waves, and then finally looking at our IVRT, and then our time delay between our mitral E and our annular E velocity. This is from the same paper, a nice visual just to sort of summarize in a table all of our different parameters we'll look at for the common special population groups. And it breaks down the special population on the left, the parameters throughout what we're going to look at, and then also if there's other supplemental parameters we want to look at over on the right as well. So it's just a nice table to look at as a reference when you're looking at these patients. Our guidelines, current guidelines, do have a top section that addresses special populations very nicely. It's a table. Again, similar to what we were just showing earlier, it has your disease on the left, and then it has what echocardiographic parameters you're going to be assessing and measuring throughout your study. So let's dig into our case here. We have a case of AFib, our patient's AFib, and there are some challenges. And each one of our special populations are going to have specific challenges when we're assessing diastolic function. Specifically for AFib, we have that beat-to-beat variability, which does affect our E to A ratio. It will affect our E prime velocities. It will affect our E to E prime velocities. It will affect our IVRT. And so we need to make sure, as sonographers, we're getting long sweep speeds, typically averaging 5 to 10 beats, because we will need to be able to average those velocities. You also have that loss of atrial contraction, so that means you have an absent A wave, making E to A unusable. And then finally, we often have our LA enlargement when we have AFib patients, which is irrespective of our LV filling pressures. So again, looking at these current guidelines, focusing on AFib specifically, these are some of the echocardiographic parameters we will look at specifically in addition to our traditional ones. Again, I like this as well as a graphic. This has our three from Smythe that has our special populations that we're going to look at. I'm specifically looking at AFib. I'm going to use this one as we walk through our case because I kind of like the visual and be able to walk through step by step of different parameters we're going to look at. So here's our case, 54-year-old male, has a history of AFib, non-ischemic cardiomyopathy, so obviously has a low EF, about 30% is what it was called. Our average TRV max, again, we're trying to average as many as we can. This is an average of about 3 or 4. It's 2.9 meters per second, so that's abnormal. This has a presence of an L wave. I just wanted to point out an L wave. I think it's often overlooked. It can be tricky as a sonographer, especially this looks like an A wave, right? So AFib patients, A-flutter patients have the fibrillatory or flutter waves. They're not A waves. So if you see something like this, it's an L wave, and so this represents increased LA pressures, and it's something to be aware of. Just so you know, if you're not so aware of L waves, again, they predict increased LA pressures. They're only really clinically significant if they're above 20 centimeters per second. And they really are better appreciated when you have a lower heart rate, or the separation of that E and A, or if you have an absence of an A wave. E velocities, about 97. Our mitral valve decel time you can see is short, less than 160, it's 153. We have E primes that are 10 and 7 for the septum. We'll look at the septal E to E prime, and that's going to be 14 based off our prior E velocity. And so just something I wanted to mention as kind of a tip, when we're looking at E to E prime, it's very difficult, and it can be unreliable because we're averaging multiple beats. Typically, I think the suggestions are up to 10 consecutive cycles. That's a lot. Obviously, we want to get those slower sweep speeds to be able to see that. I would like to suggest that we use something, if you're able to, called dual Doppler. If it's an option on I know there's a couple systems that have it. Obviously, ask your vendors if that's an option. But what this does, this simultaneously will take 2 different sample gates and be able to place one at your mitral valve inflow, one at your mitral annular, and be able to get those simultaneous velocities, which is a really nice way to get a more accurate E to E prime. Our LAVI, as we would expect, is definitely severely enlarged. Our LA reservoir strain is abnormal as well at 13%. And so let's just walk through how we would look at this and estimate LV filling pressures if it's elevated or not. So as we look at our first parameter, we have mitral valve E velocity is 97, and this is kind of close. I'm going to say that it doesn't meet it. I think we could probably maybe say it does. It's very, very close, but we're going to say it doesn't meet it. If we look at our septal E to E prime, it's 14, which is greater than 11, so that does result in a positive for that criteria. Our TR velocity is greater than 2.8, the average of that, so again, that is a positive criteria. And then finally, our E-wave decel time was short. It was less than the 160, so that is a positive as well. If you follow this algorithm, it says if we have more than 3 positive criteria, that would be considered elevated LV filling pressures. If for some reason you're somewhere here in the middle where you have 2 of each, 2 positive, 2 negative, you can then go down and apply some more supplemental parameters as well, which we'll look at a few of these in a moment. But just something to consider, and then you can kind of follow the guidelines again here. So this was from our original guidelines, our current guidelines that we have. We talked about some of these. I do want to emphasize some of these as well. I'll show these as just as an image as what these look like. But we do have some supplemental parameters. I want to show how we assess those. So our IVRT, it sounds like, will be part of more encouraged in our newer guidelines. And so I just want to make sure sonographers are getting good IVRTs. Typically, you don't have to do much different than what you're typically doing. You have your continuous wave Doppler in that LVOT area, and that typically would pick up your mitral valve. You're important trying to pick up your mitral valve and your aortic valve flows. If for some reason you don't feel like you're getting a good separation of those two or good opening and closing clicks, then move your cursor a little bit in between that mitral valve and aortic valve in a 5-chamber or 3-chamber. That will help you get definitely a more pronounced IVRT. And then you want to measure the difference between the closing click of the aortic valve and the opening click of that mitral valve. A shortened IVRT can suggest increased LV chamber stiffness. Your mitral valve E-wave specifically for AFib can tell you a lot as well. If you have variation, that's considered normal LV filling pressures. As you can see here, you have pretty dramatic variations. If you have an absence of variation, that typically would mean you have increased LV filling pressures. Typically, I had to pull this from a paper. I don't measure this or don't typically ever see this measure, but it is an option for you. It's a decel time of your pulmonary veins D velocity. You can see here they average 5, 6 of these here, and if it's less than 220, that would be abnormal. You typically look at your decel time of your E-wave of your mitral valve. You can also look at your acceleration rate. So if it's greater than 1,900 centimeters per second squared, that would also be abnormal. And then just wanted to note the new guidelines that are coming out, just from a quick, brief look that I looked at them. Your special populations aren't going to be much different. There's going to be a lot of resources for you, which I encourage, again, like we are in our current guidelines, looking at the tools, looking at the tables, algorithms to try to apply those. It's not, I want to say it's not rocket science. So definitely, if you follow your guidelines and follow the good data that you acquire, you shouldn't have any problems trying to estimate your filling pressures for your patients. So just key takeaways, your traditional diastolic function assessments may be unreliable in certain populations, which means you have to have alternative approaches. Your additional Doppler indices are really critical for these pulmonary veins, IVRT, to enhance your assessment. And then integrating these indices enables a lot more precise, individualized evaluation of your LV filling pressures in your cases. Thank you.